Hi, welcome to exciting live surgery brought to you by Dentium. We are lively broadcasting this surgery from Gangnam area in South Korea. Clinicians from all over the world, I want to thank you all for watching this live surgery from more than 10 countries. We will have implant placement with a simultaneous sinus flow elevation. We will start with a quick case preview. From your website, you can upload your questions, comments, replies, anything. So we will pick it up and read it for you. So the patient came in with a chief complaint of I have a problem with the chewing food, so I want an implant surgery consultation. And his PMH was the cerebral infarction, and he's under the medication of the aspirin, and the medical doctor recommended to stop the aspirin for 3 days before surgery. And his PDH was he extracted the anterior tooth 2 years ago, and his posterior tooth was taken 4 years ago. Today's surgical plan is to place 6 implants and 3 implants each on the right and left side, starting from canine and first premolar and second premolar. And also we will do a lot of contour augmentation or GBL in anterior area. As you can see from the clinical photo, there's a huge severe deficiency in the anterior and also the posterior areas. And also we will do the sinus elevation surgery on both maxillary posterior area. And finally, in order to deliver the temporary denture, Dr. Root will place the palatal implants. So this is the radiographic view of today's patient. And this is the final X-ray. As you can see, we have a lot of bone loss on the mandibular teeth too. So after this surgery, I was told that Dr. Root will extract additional molars. So we are expecting a few more implant placement with a lot of bone grafts. So this is the temporary denture, and this is without the temporary denture from the frontal view. And this is the lateral view from the right side and the left side. As you can see, there's a huge recession and the bone loss of the mandibular molar areas. And this is without the denture of the occlusal view of the upper arch and the lower arch. And this is the right side and this is the left side. And using his temporary denture, Dr. Root has duplicated the denture, and he has scanned it with the model scanner. And this is the information reconstructed in the screen, as you can see. And using this information, 3D printer has printed this duplicate denture. As you see, there are 4 pinkish spots, which is actually a radial opaque materials, and it gives us the information how to position this denture, and we're going to eventually merge this information with the cone beam city of the patient. So this is the sitting of the denture on the real patient situation, and it's nicely positioned on the maxilla. And we have taken the patient through the cone beam city images. As you see, there is literally no bone in this area of the maxilla. We're going to place canine and the premolars, 2 premolars, but this area is for the molar, tooth number 16. So this is the situation of the sagittal, coronal, and the axial view. And this is tooth number 15. There's a slight vertical residual bone, but still there's a deficiency in the horizontal bone. We see that we have to do a lot of contour augmentation on the buccal aspect. And this is tooth number 14. A little bit better, but still not enough bone on the horizontal situation. And this is tooth number 13. And we see a huge vertical resorption too. So this is typical Siebert class 3 with the bone loss of the horizontal and the vertical aspect. This is on the left side, starting from the canine to the molars, tooth number 23. So we have bone on the horizontal and the vertical, but not enough. Tooth number 24, and you will see that starting from tooth number 25 and 26, there is no bone. There is no bone to place the implants. Only we can do is to go for the sinus flow elevation, but I don't know how Dr. Root will place the simultaneous implant placement. How can he achieve the primary stability. Can he do it or can he not? So that will be a very, very good point to watch his surgery. And this is tooth number 26. Even worse, there is typically a huge bone resorption and a pneumatization too. So Dr. Root has used the intraoral scanner for the intraoral scanning of the maxilla and the mandible too, and he also scans the stent, surgical stent too. So this information will be given to this planning computer program, and using this program, we indicate what kind of and where we're going to place the implants. And we put the numbers to the program, and using the intraorally scanned information, it will be shown like this. And we use the temporary denture, and then we scan it again. So this information will give us quite a very nice information to merge with the cone beam CT images. Like I said before, the patient has gone through the cone beam CT taking before the implant surgeries. So this is the cone beam CT images and the scanned images from the surgical stent. And you see that radial opaque, the pinkish material is shown on these images. And using these 3D reconstructed images, we can rotate and we will see how the bone is deficient and where we have bone and where do we not have the bones. And this is the after information of the merging. So using this cone beam CT images, we have the idea where will be the surgical dent and where is the bone and where is the no bone. So after this information, we see where is the ideal position to place the implants and also acquire primary stability without creating too much dehiscences. Because if we have the dehiscences, we may end up doing a lot of bone grafts. So using this information, we set up this artificial tooth in the virtually, and we align the tooth alignment with the opposing teeth for the proper occlusion. So this will be the ideal occlusion, and along these crowns, we have to place the implants in the right position and the right angulation and the right depth. So this is the planning. Using all this information from cone beam CT in the clinical photo and the surgical stent, intraoral scan, and modal scan information, this is the final plan. So like I said before, we were planning to place 6 implants, 3 implants each on the sides, but if we are lucky, we will be able to place 2 more additional central incisor implants. So this is the planning of the tooth number 11. So there, it looks like there is a nice vertical bone and also nice horizontal bone. So we may be able to place tooth number 11, and this is tooth number 13. You see that there is a little bit of concavity on the buccal aspect, and the implant is a little bit outside of the bony housing. So in order to have a proper placement, we may place implants a little bit deeper, but we do not have enough bone and the spaces. So I think that this planning was done in order to just finish this implant seated on top of the bone, alveolar bone. So we may have to watch the long-term healing in order to see the remodeling of the bone. This is the information of the tooth number 14. And you see that the implant is starting to get inside to the sinus cavity. So it means that we have to do sinus lift. Without this, this implant fixture will be inside the implant sinus cavity. Especially today, we're going to place a new type of the aniline dentium implants. So you will have a chance to look how it looks and how it goes inside the bone. This is the information tooth number 15. And also this implant fixture is inside, more than half of the fixture is inside the sinus. And you see there is not enough horizontal bone dimension. We see already a dehiscence of the implant fixture on the buccal and also the palatal aspect. And this is tooth number 16. Like I said before, for the tooth number 15, 16 is also not either a good position to have the great implant placement. Now we go to the left side. This is tooth number 21, and this is the implant planning. And well, this is also, if we are lucky, we may place the implant on the central incisors, but we are not sure. So Dr. Root will decide during his surgery. So today, please watch, because we're going to have a lot of unexpected decisions from the surgical room. So we have to see, especially from the left side, the patient does not have enough keratinized tissue. So Dr. Root will place the palatalized incision in order to preserve the keratinized tissue. And he will move the keratinized tissue to the buccal aspect. And we will see how he ends up with the regeneration of the keratinized tissue. And also today, please watch along this video, because Dr. Root will use a very special pin. It's called a membrane pin from Dentium, but this one is for the closure of the flap. We know that we usually use the suture materials for the closure of the flaps. It requires time and requires a lot of manipulation of the soft tissue. But today, maybe he will use this pin, very specialized pin, in order to close the flap. And I was told that this is quite straightforward and quite fast and simple. So it's good for both clinician and for both patients. So we will see how Dr. Root will use this membrane pin. So this is planning of tooth number 23. And the bone is a little bit nicer than the on the right side. But starting from 24 and 25, you see that there is still bone, but 25 and 26, literally no bone to place the implant. So I don't know how Dr. Root will place implants here today. Maybe he will not, so we will watch, take a look. And this is tooth number 26. Totally there is no bone to place the implants, so maybe he will end up doing the sinus floor augmentation. And during the sinus floor elevation, please watch carefully, because he will not use the conventional particle type bone grafts. Rather, he will use the collagenated bone graft, which is easier to use, easier to manipulate. And we will see how he uses, because what I understand is collagenated bone grafts are easier to manipulate, but if you put it into the sinus lateral window, I have no idea how he will spread that bone materials under the membrane. Maybe there will be some spaces, but I don't know how he will handle these situations. So there will be a very, very good watching point. And after anesthesia and before the surgery, Dr. Root will use 2 anchor pins. We know that this is the totally mucosa-supported surgical stent. This digital stent is good for accuracy and precision, but because this does not have a hard tissue support, there will be a lot of movement, a lot of tipping, and a lot of rotations. So we have to be very, very be careful how to provide the precision. So Dr. Root will use 2 anchor pins to provide the stabilization of the surgical stent. And you see that the first pin is inside into the palatal bone. It's not in the suture of the palatal bones, but it's on the right side, slightly right side. And the second one will be on the left side. So 2 palatal implants will go inside the bone, and they will provide the stabilization of the digital stent. So I think that we are almost ready. And this information will be given to the 3D printer. So this is the final view of the digital guide that we are going to use today. We used to have a lot of flaring of the buccal and the aspects, but today we have trimmed a lot of the buccal flare in order to have a better view, because we have to watch what's going on under the drilling and what kind of the procedure Dr. Root is doing. So we have removed some flares of the buccal flanges, so it will provide us a better view. Okay, this is the final digital guide. So we see that there are many implant holes, but we are not sure we are going to place all the implants yet. Still, so far, we are going to place 2 canines and 4 premolars. And hopefully, if we can achieve the primary stability, 2 molar implants will be going in, but we are not sure because we have seen from the Conbeam CD, and I don't know, for me personally, I will not be able to acquire the primary stability, but I don't know how Dr. Root will solve that problem. And this is the 2 central incisors. So luckily, we will place additional 2 incisors. So there will be minimal 6 and all the way up to 10 implants and 2 additional anchor pins. But anyway, we will remove them too, right? And actually, this picture was taken a few minutes ago because the patient has came to the clinic, and using the final surgical stent, we are providing on top of the patient. And you see that huge deficiency on the buccal aspect. Okay. We're going to see a very short similar case presentation, and we will start the surgery right on schedule. This one was also done by Dr. Root, and this is pretty much similar case. There is a lot of deficiency of the bone, and he has performed 2 sinus floor elevation, and 6 implants were placed. And as you can see, using his temporary denture, he duplicated into the surgical stent. But this one is quite analog style. There's no metal sleeve, and there will be a lot of movement of the drill. So this is not precision type surgical stent, but this is what we had. But now we have the real digital surgical stent. So you're removing the windows and elevation of the membrane, and now he's using this collagenated bone graft, right? So this one is the right one, right? And this is after implant placement, and this is temporary denture, and this is second stage surgery after 8 months, and this is after second stage surgery, and this is a provisional restoration, and the final prosthesis. So this is what I'm expecting to see today. And there are some questions from the audiences because they usually wonder what kind of medication Dr. Root is giving to the patient. So we will come back to this later after surgery. So I believe that the surgical room is now ready. So maybe we will move on to the surgical room. I don't know how Dr. Root is ready for the surgery. Maybe he started or not. Maybe he should wait for us or not. Okay. Hello, Dr. Root. So I see the mouth of the patient. Okay, this is a very clear and high efficiency videos. We have quite a good view of the occlusion view of the palatal side. Very good. Okay, from the picture we see this is a digital guide that we see from the presentation. There are 10 holes, right? 10 holes. And we are expecting at least 6 implants placement and all the way up to 10 implant placement. Now he's fitting the surgical stent, and did you notice that the stent is a little bit slightly moving? Right, that movement. Because this is the tissue supported surgical stent, it does not have the adjacent tooth, or it does not have the bony anchorages, so it moves around. So you have to be very be careful with this. So using this surgical stent, in order to have the proper implant placement, we have to stabilize the surgical stent. I see that Dr. Root is not using the palatal implants. I don't know why, but we will see why he's not doing it. Maybe he wants to mark the areas to place implants, right? So he's checking where is the position and where is...
Can I check the position? This is fine. This is fine.
아니 여기도 위치가 적절해.
Okay. And when I check the position on this canine and the first molar is too much buccally positioned, so I will try to make a flat design on the palatal positions to make a much more keratinoid tissue on the labial side. So
It will be flat design.
with the number 15 blade.
Yeah.
And at first, canine to first premolars It's a little bit palatal side of the incision to make a much more keratinized tissue on the labial side, and the clear cut to the periosteum, and a little bit. Okay.
Okay, like I mentioned before, he wants to preserve the keratinized tissue. We also
In
noticed
this
there's
side,
a lack
the
of
bone is
keratinized
relatively
tissue.
good, so I will try the two minimal invasive surgery in the left side, but in the right side, I will do incision and very typical GBR technique with the sinus augmentation together. But in this side, is the drilling position would be much better. Sometimes it can be rotated. So at first, I will try to do vertical incision on this side, and it will be lingualized incisions. And also for the sinus augmentation, I will extend it to the first molar areas. Yes, I will try the two incisions.
Okay, I get the idea. So in order to decide where to place the incision, he used the surgical stance and he slightly marked
avoid
the
the
ideal
incised canal
positioning
area.
of the implant. And now using this information, he's placing
And
the
another vertical
incision.
incision in the
So on the left
posterior
side, it was the palatalized, and this one is quite
and the little
mid-crastal,
bit palatal position, the incisions.
a slightly palatalized incision. So very, very nice technique, because using only surgical stance, he will not have
Bone is
the
very
information
thin,
on the
so
soft
it is
tissues.
very important to have a exact drilling, the alveolar crest or not. So during the procedures, you will check the
So he's placing quite a large incision because we have to place at least 3 implants,
Positioning of the
1 molar,
implant
sinus lift,
site.
and the bone graft.
with the relationships is the surgical stent. First to do, I will do a clear cut, but for the more conformations, for the flap retraction, I will do little bit more clear cut
So in order to have the proper
to the periosteum.
minimal trauma flap reflection, he's
Because
using
during
the
the
clear
flap
cut
retractions,
of the incision, and he's using the
to avoid the periosteum tearing,
mold curate or chisels.
to avoid the postoperative pain and swelling.
Okay, we see the bones inside, very good. This is what we expected from the condom cities, so not enough buccal
After
bone,
that, I will
but
put
the anterior area looks quite nice bone quality.
during the flap retraction,
It's using the mold
forming,
curate to have
attach
the
the instrument
detached of the buccal
to the
flap,
periosteum,
clear
for the
removal of
clear-
the periosteum.
retraction of the flap, with your minimalized periosteum tearing. Already little bit tearing on this side.
So he's paying a lot of attention
Step
not
by
to
step.
damage the periosteum, because periosteum is very important for the regenerative healing potential. So he's not increasing damages to the periosteum. He's being very careful with the
Sometimes
soft tissue
in
management.
eventrous areas during the drilling,
Now
the
he's going for the
surgical
palatal
stent
aspect.
can be little bit rotated, so the position usually is not correct. So you must be cautious, and at first we will check on this side.
Okay, the mid-crastal area of the posterior region is quite flat, so I think that we may place the implants nicely fitted inside the bony housing.
At first, it will be flap retraction to the palatal side. As
Wow.
you see, in the
He's
complete
going-
dentures,
He's going quite
alveolar ridge already
okay.
became to be very thin horizontally, not so much vertically. So compared with the vertical augmentations, and the horizontal augmentation is relatively simple.
So the
So
ridge
checking
looks
the
like the
venous-
indication for the ridge splitting, and we will see that how Dr.
Also,
Root will
later,
do the ridge splitting or not.
bone augmentations, I will do completely removal of the soft tissue at first with the hand instrument, sinus augment.
Because we're going to do a
later on,
GBL, the soft
we do
tissue will get in the way, so we have to
diamond burr.
completely remove the soft tissue remnants from the bone. This is very important.
제끼고, 제끼고, 주머니에 껴줄까?
Alright, we have a very great view of the surgical site. Horizontally may be compromised too
And
much
I will
for
try
the
the tooth.
implant placement on the tooth number
Completely grinding
11.
out a
But
soft
maybe
tissue.
we'll have no problem. Oh, he's using diamond burr to remove the soft tissues. Okay, I thought that he will use some kind of hand instrument, but now he's using this rotation instrument to remove the soft tissue. That is quite fast, straightforward, but there is also chance to remove the bone itself. So the clinician must be very careful not to damage the bone. But I see that this one is quite easy because it irrigates
After the
lines
complete grinding
together.
out of the soft tissue,
And we see the nice, white, smooth bone surfaces already. This is a quite very good technique. I don't know if this diamond burr, the big size diamond burr is coming from Dentium, but maybe I have to use that sometime. This is quite easy to use, I think. Now he's clearing the site for the surgical site to have the better
after that,
view.
with the hand instrument, I will do.
Okay, he's using now again the hand instrument to remove the soft tissue from the bone. So we see that he's spending a lot of attention and the time to completely remove the soft tissue. So as a general clinician, we do not spend too much time on removing the soft tissue, but I think that, wow, this is the secret of the nice results from Dr.
리치
Wood.
스프레더도 준비할 때, after that, I will try to position the surgical stent again.
And also the viewers from all over the world, please leave your comments, ask questions, and anything from your window. Please leave any comments. Okay, I think that Dr. Root is ready for the stabilization of the surgical stent using the palatal anchor implants. And
I will try the positioning.
okay, he's using the drill. He's using the drill.
For the anchoring.
Okay, that was easy, very easy, straightforward.
To anchor.
Using left hand, he stabilized the surgical stent in one single position without moving. And now he's using, okay, that's the palatal pin. I thought it looked like
this
implants,
surgical
but it's really pin. You just push it.
Okay.
So it's the push pin. Push pin is going to the palatal bone, and now these two pins provide the stabilization.
At first, I will try the positioning canine to first molars.
So he is starting to osteotomy on the canine side, on the right, upper right. And we know that there is not enough bone. I don't know how he will start to the osteotomy.
I will try. But
Still, he is doing a lot of the left hand
not easy to
manipulation in order to provide the stabilization of the surgical stent, not to move it.
First premolar.
Okay, he's doing the premolar first. So this surgical stent does not have enough space for the coolant to get inside, so there's aggressive coolant coming
But
from
canine
the
area
outside.
the bone is too much thin, so it is not easy to place the implantations in a very thin alveolar ridges. So at first positioning
So his first
in the
drill was
first
done.
premolar area.
Now he's doing the second drill. Okay, he's now going back to canine bone.
So you must use the ridge spreader. So I must do the ridge spreading.
Okay, like I expected, he's doing the ridge splitting technique, his favorite technique to
I will
preserve
try
the
first with the
pristine bone.
Initial drilling. After
Still,
that,
he
I
has
will
to do
try
the bone graft, GBR,
is
but
spreading.
he's doing the ridge splitting to maximize the healing potential of the autogenous bone. Yes, it will be very difficult to engage the drill because
After
there's a
removal
slope of the bone.
of the ankle
So
pin.
Dr. Root is having a slight difficulty to start the osteotomy in the canine aspect.
For the
Okay.
positioning of the canine, I will remove surgical stand.
Okay, for the canines, he remove the stent
do
and he's
rigid
doing the brain
spreading.
guided. This is the, please audiences, this is a brain guided freehand
네,
implant surgery.
말렛 준비를 할 거예요.
The surgical stent was quite difficult, so he's doing freehand brain guided implant
After
surgery
checking the width,
using ridge spreading chisel from Dentium. He's using his mallet on the right side and the chisel on the left side, and he's
That
going
bone is
inside the
is
bone
too
and
much
spread it,
So I
the
need
buccal
to be
bone,
more
by
spreading.
creating a green stick fracture. And this buccal bone should not be lost. It's going to the buccal aspect, and it will provide the surrounding of the implant fixture. Okay, this is the rotational micro saw to create the indentation along the ridges. And after you create these indentations, it will be easier to insert the spreader inside the vela bone.
After the initial grinding out and the ridge spreading, little bit more widely. Yes.
Okay, he's using the spreader again. And because he has placed the indentation on the cortical bone, now he's going inside the cancellous bone, and it's easier to split the ridge. Okay, there's a green stick fracture, and he's paying a lot of attention not to break the cortical bone.
Step by step. 괜찮으세요? I will try the repositioning of the surgical stand. Pin 두개.
with the pin.
Okay, now he's connecting the 3D surgical stent again. I think that he's ready to go for the canine areas.
됐습니다. And try to drilling start again. First with the short drills. 6 millimeters at first. And later on,
Okay, there was a question regarding why Dr. Wood is
Around 9
removing all the
millimeters,
soft
but
tissue
I will for the
on top of the
TBI,
bone.
will do
That was a very
11
quite a very important
millimeters
question.
more.
Because we are expecting a lot of the bone graft. And on top of the pristine bone, if there's a soft tissue, if we graft the bone materials on top of the soft tissues, there will be already soft tissue impingement, and it will interfere,
First implant,
not really
I will
interfere,
place
but
the
there will be a
first
slight chance of the
two molar
interference of
areas
the
with the
bone
3.8,
regeneration.
3.3.
So
3.3.
it was a
3.3.
question from Dr. D. And also there are many similar questions. Why must be clean bone from soft tissue?
3.3.
So maybe we will believe that it's not important because we're going to place the implants and we do the bone graft after all. These little small fiber tissues are not really important, but in order to maximize the bone regeneration and in the very extreme cases like this, we have to do what we can do to maximize the best healing.
Okay, with the
So this is why we are
50
removing the
without
soft
irrigation.
tissue remnants from the bone. So thank you for giving me a very great question, Dr. D and Dr. Edmund.
And I will try
And
to
now we are
place
placing the
implant.
upgrade version of the NR implant, Dentium NR implant, 33.9 millimeter, 3.3 diameter, and 9 millimeter length. And connecting to the mount, you have to be careful to go inside the metal sleeve. there is an oxide layer of the implant fixture, and if you touch and contaminate the surface, so it's
Sinus
not good
little
for
bit
the
perforated, so
osseointegration,
I'll
so
delay
you
the
have to be very
implantation
careful.
after the sinus segmentation. Okay. 여기 타이타늄. Little bit complicated cases, so it is difficult.
Another question from
after
Emma
removal of the-
Burglas. Hi Emma, you asked, what have you used? Why have you used palatal to fix the guide? That's another good question. If a conventional approach is we can stabilize the stand from the palatally and also from the buccally. But today,
Sinus during
this
the
is
drilling,
the
sinus was little
area
bit
we have
perforated.
to see for the audiences.
Okay.
So that's why we did not use the
During the
buccally
regular approach,
anchorage
I will do
pins
open the
because
problems.
there will be buccal flares of the flanges
for
of the
the-
surgical stent, and it will be very difficult for you to watch.
Yeah.
So that's why
For the
we,
drilling of
especially
the
because we have a lot of
canine
spaces on
areas
the palatal aspects.
And forward and
we
lean
use
forward.
the palatal pins. Thank you for the good question.
Next is 3.3.
We were ready to place the
Forward.
implants, but he's
Even.
going a bit hesitant
Okay,
about the implant placements. We will see why he did not place the implants yet. This is the tapping drill from the ridge spreader. So it goes inside, it creates the tapping holes
I
for
place
to
the
place the
implant
implants,
on this
but
side.
also this one does the expand the alveolar ridges
Little
all
bit
around
difficult cases.
area directions.
But
So this is another good items from the
Fine.
ridge spreading kits.
yes, 3.3.
So it was a very nice touch to split the ridges.
At first,
So we can place the implants
the canine
inside the bony housing of the autogenous bone.
to the alveolar crest.
Okay, he's stopping. Okay, going a little bit deep, maybe, okay,
So
that was the
very fortunately, we have
equi-mid-crustal
placed
implant
implant.
placement.
Inside the bony areas, but labial and palatal bone is, especially labial bone, is too much thin. So thin alveolar bone will be reserved. So we must do augmentation on this side.
Okay, so we can see that there is a crack in the
The
green
next-
stick fracture on the buccal aspect
To
along the
overcome the
implant
sinus
fixture, and we
problem.
see the grayish color
And
of
right,
the implant
sinus
fixture on the buccal
augmentation.
aspect. It tells us the bone is extremely thin. So we may have to do the bone graft for the future prevention of the dehiscences or
This is the first
exposures.
premolar side. So approach to the on this side, the lateral approach.
Okay. Instead of placing first premolar, he's not placing it, but he's
And
putting
very
the parallel
simply
pin
grinding
inside,
out.
and he's not.
And
he's
this
not
is a
finishing.
diamond coated
He's
ball.
taking up the diamond bore, and I think that he's going for
Also,
sinus lift.
this can be used for the grinding out of any soft tissues over the bone. Yes. You
So
can
we
see the
will see
little bit
why
gray
he is
color
doing
on
the
this
sinus
side.
lift at
That
this
is the
point.
sinus. So
Maybe
approach
premolar
the
areas did not have enough
lateral
vertical
side.
dimension.
And you can see that some gray color can be exposed. That is the membrane. So little bit grinding out. Approach is a lateral approach because the outside is a high speed. If the membrane is exposed, I will change it in the perpendicular.
Oh, he's changing the angulation. First, you have to cut
Okay.
the bone. It
And
goes
with the round
perpendicular area,
instrument.
and then now he's tipping the drill 90
Initial
degrees.
detachment of
Okay.
membrane. During the force, and the membrane was little bit teared.
Okay, there is a membrane perforation.
Okay, I must overcome that.
Okay, that was
Very small size,
quite
so it's
quite
not easy.
big jump
So I will
inside
try
the
to
sinus
make a
floor.
window a little bit
Okay, we have
wider.
to be. This is a very good way to see how Dr. Rook is overcoming this problem.
Sound is very
This
big.
is a quite common situation for all of us during the clinical situations. Now, without touching any
Because
more the membrane, please see
Membrane
that
is teared,
he's
so at
expanding
the
the
time,
window. He's
you must be
skipping
very
the area.
cautious.
He's looking for the
to
intact
elevate the
area.
membrane.
Very nice technique. Okay, he's going
You
for
must
the
make a
clear
window
area,
little bit wider
widening the windows.
to prevent the widening of the tearing side.
Okay, he's using the diamond burr
You
very
must
well.
a little bit grinding out,
He's going for the
much wider.
Now there's a perforation about 2 or 3 millimeters, but
And try the two,
because he has widened the windows,
the membrane.
now he's only playing with the intact membrane. And
Very
this perforated
cautiously,
area will
not to
be reflected all the
widening
way
of the
together
third
with the
side,
intact
very
membrane.
cautiously.
So now
must
he is
do
paying a lot of
this.
attention not to damage the perforated area.
Membrane elevation, it will be far from the opening side.
Using the mushroom probe, he is going
And at first,
360
after the
degrees
initial
circulation all around the windows, and he's going for
I will try
this
to
is
approach.
dusk elevator number 2 or 3, I believe.
Another tearing in the optical
So
area.
3, I believe, yes. This one is going for
It will be difficult to overcome
coronal
this problem.
aspect, and medial aspect, and the distal aspect. So it has a quite steep angulation. It's easier to go for the coronal floor, sinus floor aspect.
So to reduce the tensions on
Now
the
he's
tearing
paying
side,
very
I must
a lot of careful
elevate the
attention not
membrane
to damage the
far away
membrane
from the
further.
tearing side. And step by step,
So he's going for all directions.
very fortunately, we
Very
have
good.
overcome that problems. And
Okay,
the
did you see the movement of the
instrument
parallel
tip
pin?
touched
He's touching the pin.
apex of the
Yes,
parallel pin.
he's
So-
touching the pin. It means that
I will try to
his
little
first
bit
premolar
widening
pin is inside the sinus cavity. So that's why he stopped
Of the window.
placing implants.
the anterior side.
He wants to expand
소리가
the
좀 많이
window
나시죠?
all the way to the
죄송합니다.
premolar areas. That is a quite powerful drill. You can remove a lot of bone quite fast.
Okay. After that, very big sound.
Okay,
After
usually
removal
it's very difficult to observe this area, but the assistants are doing a very good job to provide a very good view from this direction. Usually it's very difficult to have a view like this. Now he's using the dusk elevator number 3 again to further elevate it. Now he's touching for the floors. We see that floors, okay. And you can see that perforated membrane is now safely reflected with the intact membrane. This is number 4, elevator number 4, and he's touching for the holes, the osteotomy side. So he wants to also include this perforated area from premolar and lift it together with the intact membrane. You see that? This perforation was 3 or like something like that, but now it's even smaller because the membrane is reflected altogether.
Let's check.
So this is how you manage the perforation. From the literatures, we were told that we do the sutures, or sometimes we have to come back 3 months or sometimes 6 months later. But if the perforation is not too big, the way we do is we circumvent it. We go for the other ways, and then we elevate the membrane, and indirectly this perforated membrane area will be reflected together.
Where?
So you have seen a very nice management of the Schneider membrane.
됐습니다.
Okay, okay. Oh my God. Okay. The patient has pushed too much air,
Very
and
difficult.
there's a little bit more perforation.
괜찮으세요? 좀 어려워졌어요.
So you have to
Very
give a lot of
difficult to do.
precaution to the
Very difficult
patient,
surgery.
because during this surgery,
must
the
simplify.
patient should cooperate together.
So easy. 네.
We tell the patient to breathe in and breathe out, and sometimes
So
they do
during the
it
sinus
too
augmentation, you
aggressively,
must be very cautious.
and that's what happens. Now the perforation is even bigger. I don't know how he will handle to manage the perforation. He's checking the sizes, and I don't know, maybe he will create the window too distally or continue the elevation. Okay, he will continue the elevation of the membrane
Membrane little bit more.
all the way to the distal
Easy
aspect,
close
I
of
see.
them.
Okay, the membrane is now again detached again, and this
Usually
perforated
in
area.
this situation, if you difficult to overcome this problem, at the times and closed the sinus and this surgery 2 or 3 months later.
Okay, he's saying the same thing. If this perforation is too much, you have to come back 2 or 3 months later.
Usually it's not, it is very difficult to sutures in the lower materials, membrane to membrane. So 이거 콜라겐 리저버블 슈처 하나만 좀 해줄까요?
Okay, I think that he's going for the sutures. Wow, that is not easy. That is not easy to place the suture. Movable
It is
Schneider
very thin and
membrane
very easy
in
to
the air.
source.
I don't know. We will have to wait for his decision. He's thinking really hard. He will continue the elevation
여기다가
or not.
말레스에서 홀 하나만 만들어 볼까요? 네, 벽 위에다. We tried to sutures.
Okay, he's going to the sutures. Wow, yeah.
쐐기 같이.
The assistants are ready for the 506, the resolvable silk.
Make
maybe.
one hole and we tried to sutures.
Okay, conventional implant surgeries is now quite common among all the clinicians. We see how to place the simple implants placements, but
봉합을
the problem management like today is very rare to see, very rare
surgery
to
became to
observe.
be a little bit hard.
And I think that today we have a very nice experience of how to manage the perforation of the Schneider membrane. There are many ways, other ways to overcome this problem. We can use the resorbable membrane, and it's called the Loma Linda pouch because it was brought from the Loma Linda University. They put the collagen membrane inside, and then they put the bone grafts. Just
코로
like
물이
the
들어가는
dumplings.
느낌이 드실 거예요, 선생님. 조금만. 예. 뱉지
Going
마세요,
for
선생님.
additional window creation.
To widening little boy is would be much more convenient. So after a little bit more widening, 갑자기 수술이 쌀쌀이 맺히시거든요.
Okay, we have some questions from the audiences. Dr. Easter, and he asked about the side effect of the membrane perforation. Well, we lose the bone particles. We lose the bone particles and we end up having no bone regeneration or minimal bone regeneration. So in order to prevent it, we are going to place the resorbable membrane first and then put the bone particles.
콜라겐
But
그래프트
today, Dr. Root will use the collagenated bone particles, which will provide the stabilization of the bone particles themselves. So maybe we will have less problem of the loosening of the bone particles. And also the infection and the inferior bony healing is expected from the sinus membrane perforation.
그래서
So we will
after
have to
the
see that.
widening and very fortunately not so much exposed. So I will try to approach the collagen graft. 이건 뭐죠?
Okay, this is called collagen graft. This is a collagen membrane, but as you can see, it has some thicknesses. It's kind of a 3D matrices, and it's also, of course, resorbable membrane. So I think that the size is 20 by 30 millimeter size, and he's inserting the membrane.
Instead
In
of
this case, it's
articulate
collagen
bone,
graft
I
inside.
try to place the
And
without collagen,
without
usually
putting the
at this
whole
time,
graft
I
inside,
place
but he's
collagen.
holding the tip of the membrane because he wants to prevent the insertion of the membrane altogether. So he's stabilizing the membrane with his left hand, and he's picking up the osteon 3 collagen.
이쪽으로 기구들을 타고.
I don't know why he's not
And for the placement of the-
hydrating. It looks like it's already hydrated. Okay, I see. This osteon collagen 3 particle is hydrated slightly, and then he's placing it, and he applies the condensing force all the way to the medial and the coronal aspect. That's where we want the bone to be regenerated. So he's putting the osteon 3. It looks like osteon 3 collagen 6 by 10 millimeter, and he's using 3, I think, so far. He's using 3 osteon 3 collagens inside the sinus. And he's pushing down with the mold curate
on this side.
all the way to the coronal aspect to better stabilize it and also better bone regeneration.
Surgery became difficult.
Dr. Eric Amslam asked why Dr. Root is not using the OSCE system, but in fact, this big diamond burr is a simplified form of the DAS kit, sinus kit. So you get your request to your dealer, and they will provide some information of this big size diamond burr. Okay, he stopped pushing the bone graft inside the sinus window, and he's augmenting on top of the windows and closing it with the collagen graft. So this collagen graft was used to protect the perforated areas, and also it is using to close the windows, lateral windows. Okay, very clever way to correct the problem. And now he's ready for the implant placement. It was 3.8 diameter and 9 millimeter long implants. It's an upgrade version of NR line implants.
And the first molar site also not so much widened.
Okay, is he ready for the first molar implant placement? It looks a little bit too thin for me, and he's already grafted inside, so I don't know, he will go for implant placement or not.
Instead,
This is the second premolar. Okay, canine, and this is the first premolar, and he's looking for the positioning of the second premolar. He's using the parallel pin. It's coming from the desk kit, it's inside, you take it out, and just like using the healing abutments, you can rotate it inside the implant fixture, and it gives you the angulation, depth, and the positioning, and you get the general idea. Okay, Dr. Root is ready for 3.8 and 9 millimeter length implant fixture again, and it will be going into the second premolar area.
이제 2번으로.
So it was quite fast, I see. 3 implants placement, and the sinus window creation, and the bone graft, and everything, and also the ridge spreading. So a lot of surgical techniques are shown today, only for the right side. So I don't know what kind of techniques Dr. Root will show for the left side.
It's a bit difficult.
Okay, Dr. Nipen from Thailand,
It will be
he asked us about why the stent is mobile during the drilling,
step by step.
and will it cause missing direction, and how can solve that instance. That is a quite very good question. This is, like I said before, this is a totally soft tissue supported surgical stent. So we need a very strong, very rigid stabilization. That's why we have placed 2 anchor pins. But unfortunately, after the first initial drills, Dr. Root is not using the surgical stent anymore. So we only got the information of the implant location, but the angulation and the depth and the positioning itself is going from his experiences, clinical experiences. So surgical stent was only giving the information regarding the position. And now he's doing the bone-driven, the implant into the bone,
For the bone
in order to
augmentation,
provide the
instead of the
stabilization.
cover screw,
Okay,
try the
that is
flat
another very
short
nice
healing
instrument. In order to connect the healing abutments, we usually use the right hand or left hand, single-handed, but this one gives the better grip of the healing abutments, and if you rotate it, and it gives the another 90-degree different rotation, and it's easier to connect the healing abutments, and you can get the information about the torque, final torque of the healing abutments. So if you do not have this instrument, maybe you can ask
first
the
premolar area,
dealers
second
where
premolar
you can
area.
get this instrument.
I press the cover screw.
Okay, in this area, because this is the sinus window area, he is afraid of connecting to healing abutments, and in this area, second premolar, he's doing the cover screw. He will go for the primary
네
closure, I
번째를
think.
한번 줘볼까요? First.
Okay, premolar and first molar
세 번째 줄까? 제일
are
끝으로.
pretty much covered from the sinus lift. If only the bone heals well from this perforated Schneider membrane, but I see the implant placement was quite successful, and we have to do the contour augmentation on the buccal aspect.
The surgery became to be a little bit difficult, but membrane은 교체를 했었네.
So like Dr. Wood said, surgery is going very difficult at this moment, but we have to expect everything. But there is a saying that expect hope for the best, but prepare for the worst. All these planning were already inside his planning, so he was ready for all the instruments, all the equipment, biomaterials were ready at his hand. So all the assistants knew the drills and they were familiar with the protocol, so that's why after perforation he delivered the collagen graft and the bone osteon collagen, and now he's using another different type of the membrane and also membrane fixation pin. Ladies and gentlemen, please take a very nice look at the membrane fixation pin. It's coming from Dentium, and from perpendicular angle, with your left hand you stabilize it, and with your right hand using the mallet you stabilize the membrane just like that. Quite easy and straightforward. Personally, I use this membrane, and in fact I'm a very great fan of this technique. This is similar to the sausage technique from the Dr. Auburn. After stabilizing the resorbable membrane using the pins or screws, Dr. Root or Dr. Auburn will do a lot of bone graft under the membrane, and they will provide the stabilization because these two pins will stabilize the membrane, and because you pack the bone graft under the membrane, there will be a bulkiness of the bone, and also there will be a lot of stabilization by himself. So without using any Gore-Tex non-resorbable or titanium meshes, but nowadays many clinicians prefer to use this resorbable membrane with the pins. What happens after 4 or 6 months later? We notify the patient they have the additional pins, and many clinicians do not remove the pin. If the soft tissue is thick, they just leave the membrane inside, and the patient are aware of the presence of the pin. That is okay. But after a couple of years later, if there's an infection or dehiscences, we can remove the pin very easily.
I'll be grafting in a conventional method.
This is the osteon 3, not collagenated. This is osteon 3. This is osteon 3, the particulated bone, hydroxyapatite and the beta TCP mixed together. This is a synthetic bone and particulated. If it's collagenated with the 5 and 8% collagen, it becomes osteon 3 collagen. Now he's carefully pushing the bone all the way to the bottom because he wants to minimize the dead space. And look at this. This is a very, very nice bulkiness of the bone. During the healing period, we have to expect the shrinkage of the bone particles, but so far the bone augmentation was quite nicely done. And he's augmenting on the palatal aspect too. Okay, now he has, please remember that he has connected healing abutments and he's doing the GBL. Does he want to close it? Or does he want to
for the fixation, I will
transmucosal GBL? I don't know. We have to see. This is a very quite interesting cases today. Okay, he's using additional membrane pin to the palatal aspect because he has reflected a lot of flap from the palatal aspect. It's easier to approach. So you see the sound of the malleting, and 4 or 5 malleting, and the pin is all the way to the bone, and you tip the holder, and you can easily remove the pin from the holder.
Also on this side is too much thin, so you must do a little bit more augmentations on this side.
Okay, he wants to do augment on the palatal aspect of the premolars, 2 premolars. I don't know why he's connected healing abutments and he's doing the GBL. Maybe he should have connected cover screw. I don't know why. Maybe he wants to over-augment it on top of the implant. So that's why
So
he has
for more
used
augmentations
healing
on this
abutments.
side,
Another resorbable collagen membrane.
Also we must do fixation. 조금만 조심하세요. 조금만 조심하세요.
Okay, this is additional collagen membrane, and he's using the membrane pin
조금만.
on the crassal aspect because there is no implant in this area. And did you see the slight tipping of the holder? It just detached just like that. It's very easy to remove the pin from the holder. You don't need additional instrument to remove the pin from the holder. You just tip the angulation and it's automatically detached. Now he's using this osteon particulated bone again.
You must do
Okay, he's
Little bit
now
more
he's doing it again. He's over augmenting on top of the implant fixture. We have placed the implants at the bone level, but we have to expect the shrinkage of the bone and the condensation of the bone. So he's over augmenting the bone particles on top of the implants, and in that way we will have the proper bone volume. Otherwise, after 4 or 6 or 9 months later, we go for the second stage surgery and we see no bone. So that's why he's doing the over augmentation, 130% or 150%. Okay, he's doing another membrane pin. That's the number 1, 2, 3, 4, 5. 5 membrane pins were used. Okay, he's using a lot of membrane pins, and hopefully today he will show us how he closed the flap. I told you we use the sutures to close the flap, but he will be using another different type of the membrane pin to close the flap without any suture. So Dr. Root told us that it's quite easy to use and it's quite straightforward, and the result is quite nice. So we will have some luck today to see how this membrane pin for the flap closure will be used. So he's doing a very nice periosteal releasing incision. Usually the periosteum is 0.5 millimeter or up to 1 millimeter thickness. So if you cut the periosteum properly, you can advance the flap with no problem. But if you go further, you can advance the flap even more, but there will be a lot of bleeding and the cutting of the muscle, and there will be a lot of pain from the patient. So that's why he has stopped releasing the flap, and now he's ready for the closure. At this point, if the assistant retracts the lip too much, it will be difficult to have the proper measurement of the flap advancement. So the assistant has to let the strength go a little bit and then release the lip, and he's ready. All right, I think that he's ready for the closure. He's using the 3.0 silks. I wanted to ask Dr. Root why he's using the healing abutment and what's the height of the healing abutment, because if it's too high, they will be very difficult to have the closure. Okay. Dr. Root used 2 millimeter high healing abutments. So it's not really high, so there's not enough problem. They will be easy to have the proper closure. Because we have seen that Dr. Root has done a very nice periosteal releasing incision. You see that? Okay, he's not using the suture. Okay. This is what I said before. He's using this specialized membrane pin for the closure of the flaps. This is quite far from the conventional surgical techniques. What we observe today is quite different from what we learned from the textbook. But he's doing a very, very innovative way to have the surgeries. Luckily, the patient does not have too much bleeding. We were told that he's under the aspirin taking, but he stopped aspirin 3 days ago, and the bleeding is quite very nicely controlled. Okay, so Dr. Root is still trying to stabilize the flap with the membrane pin. Please be noted, this membrane pin is different from the conventional membrane pin. It has it has more length, so it's a little bit longer. It's a little bit longer. So okay, he's using the only one pin for the angular area, and now he's moving on to sutures. So okay, I see that he was wanting to show us that he is using this special GBL pin to close the flap, and the other areas he's now going back to the basic, and he's doing the suture with the 3-0. Dr. Srikanth was asking why wasn't the denture ball was considered, and what kind of membrane was used for the sinus, especially for the perforated areas. The question number 1 about the denture ball is not quite popular or well known among the Korean the countries. So we have not enough clinical experiences with this type of birth. So we have seen some cases and we have seen many congresses, lectures, but we are not really ready to utilize the birth. So at this point, we did not consider to use the denture burr. And the membrane Dr. Root used was not a membrane, but it was a collagen graft. It's kind of a 3D matrix. So it allows a lot of blood supplies, and it attracts a lot of fibroblast, and it heals very nicely. So instead of using collagen, very thin collagen membrane, he used the collagen graft. Okay, he's going for the posterior areas. And I see that today he's doing a lot of the open healing technique. If he used the Gore-Tex membrane or titanium mesh or something like that, maybe he had to perform a lot of flap advancement to have the primary closure. But because this was the resorbable membrane, there is not enough no problem to have the closure. He's doing intentional open healing closure.
There need to be more argumentation on the labia side.
Okay, I think that he has seen that the buccal contour augmentation was not enough.
Also,
so he's doing the additional bone graft. So the osteum collagen graft was grafted, and we see that particles is maybe falling out. So Dr. Root is grafting this again, the collagen graft, not the collagen membrane, but 3D matrix. Collagen graft is covered on top of the osteum 3 collagen, the bone particles, and he's closing it in the open healing approaches, I believe. He's not going for the primary closure because I see some tensions of the flaps. Okay. Maybe interrupted suture. Yes, he's doing the interrupted suture. And he's tightening it, but it's not enough. So complete primary closure is not possible.
So you must relieve the tensions.
This is only open healing procedure, and he's checking for the tensions, because if there's any tension left, there will
try
be
to match
dehiscences, and dehiscences induces
side.
exposure of the bone particles and implant fixture and also the sinus window, so we have to be very careful not to leave any tensions. And in this case, this is not the interrupted suture, but maybe horizontal internal matrix suture in order to invert, okay, invert the flaps. Did you see that? The horizontal internal matrix sutures provide, okay, the suture was broken.
핀셋 하나만 줄까?
Very, very powerful suture technique. The suture was 3-0 suture. Okay, that's, maybe he can do that, all right.
안될 것 같아.
This is the level of the microsurgery. This is what we can see from the microsurgery, from the broken sutures.
두 번 감아야 되는데 한 번만 감아도 그래. 한 번만
We should pray together. Maybe he can get a great tie. Okay, we see many hands are helping him.
네, 다시.
No, he just gives up. Okay. But it was a very nice try. I sometimes do that too because I want to save time and I want to save the suture materials. But this one did not go well. Now he's doing the suture again. Horizontal internal matrix suture again. Or just interrupted suture.
너무 in this side the surgery became too complicated, so
Okay, he's doing the
I saw
horizontal
you.
internal matrix suture again.
You the very simple, so much complicated. 이 정도에서 맞는데. 소재로 줄까?
Okay, the surgery on the right side with the 3 implant placement and contour augmentation and the sinus lift. And we see that there is a irrigation. It's sometimes called showering because we do not want the soft tissue to dry. The dry soft tissue usually gives us a lot of inflammation and the bad results usually. So we have to let the soft tissue be always wet. So keep showering. And he's using different size of the silks. It looks like 40 silks. Okay, he has used membrane GBL pin in order to have the first closure, and then he's using the suture techniques all the other areas. Maybe he can leave the pin, but also he can remove the pin. So we will see what kind of decision Dr. Wood will make. All right, there is some exposure of the collagen graft. Okay, that's where I mentioned. So he's pushing it inside, and I think that he will go for the closure. All right, this is very interesting because it looked like it was going for the open healing, but eventually he's now having a very nice primary closure. So that's it. All the areas are now properly closed using 3-0 silk and 4-0 silk and the membrane fixation pin with a little bit length. So it was used to close the flap, and he's checking the lip to see that if there's any tension from the lips. The reason he's checking for the tension is if there's any tension left during the chewing, talking, and a lot of tongue movement, the flap will receive a lot of tension, and it will end up with the dehiscences and the infection and exposure and everything. So he's checking tension excessively. So totally 2 collagen graft, 20 by 30 millimeter was used,
왼쪽으로.
and 2 collagen membrane was used for the upper right areas. So it was a very nice operation. Maybe around 50 or 60 minutes
Finish the surgery very simply.
was required. And he wants to, he mentioned that he wants to do the simple surgery here.
I must check the width. 아프세요? 네? 예, 아프지 않았어요? 네.
Okay, thank you, Zach. He used the proper word that I forgot to mention. He was talking about the tenting
This side
effect.
is relatively good.
The reason he used the healing abutments, 2 millimeter height, in order to have the
Little
tenting
bit
effect.
palatal
Thank
position
you,
is
thank you,
better.
Zach.
그렇죠? 잠깐만. 한번 인셔.
So I believe that Dr. Root will be very tired from the late hour aggressive surgeries, but he's, without taking any pause, he's going for the second surgical side on the left.
Little bit repositioning.
So he's going for the canine and 2 premolars. And I don't think we are going to place central incisors today. So we are only going for canines and the 2 premolars.
이쪽은 사이너스가 더 가깝죠? 어떤가요? 5번 V에 디자인할 때 어땠어요? 이쪽이 더 20번대가 더 가까워요? 아, 좋아요. 예, 오케이.
Okay, he's, because he has used the digital surgical stent and he marked the positioning of the implants, and using this information, he's doing the on-site decision again. The information
그럴 것 같았어요.
told us that we have to go
이쪽은
for a little bit
삼삼이었죠?
buccally
아니, 또
located implant
삼삼의
placement,
분이
but he wants to minimize the instances, and he's going for the other areas to place the implants.
38이었어요? 그럼 38 좋습니다.
So it's very interesting. He made all the surgical stents, and he's using only for positioning of the implant fixtures.
2번.
But still, we have a very nice information of the bony anatomy, because we have seen Conbeam CT, we have seen clinical photos and oral intraoral scanning, and it means that we were doing a lot of planning.
좀 길은 거 심으시죠.
Like General Eisenhower once said, planning is everything. Plan is nothing. We have plan, but it can be changed. But planning is very important. We had done a lot of planning, and from this planning, we are planning it on-site decisions, and we are going for a better way to have the nice healing results.
그게 좋을 것 같죠?
So here's going with the first osteotomy,
오케이.
and he's going for the second osteotomy. Let's go back to the question from the audiences, international audiences. James, he's wondering which is good, or small GBL with primary closure, or large GBL with open healing. Regarding open healing, we do not have any long-term data, or we do not have any scientific evidences as compared to primary closures. So that's why we are careful with the open healing. But so far, using the collagen membrane, resorbable collagen membrane, we are seeing good results with nice regeneration of the keratinized tissue. That's why we are going for open healing. And also it's good for clinicians and also for the patients too. So maybe we're going for that direction, to the open healing. But right now,
좋을 것 같죠?
small GBL with primary closure will give us more evidence-based results. Large GBL with open healing, less evidences, but if you do properly,
쉽게 끝나야
you
되는데
will have a
쉽게
good results.
이쪽도 그럼 사이너스 엘리베이션까지.
So Dr. Root is having a hard time today because now you see the bleeding is coming back.
이쪽까지 해서
We were told that the patient is under the aspirin, and now the bleeding is back. Because why? I assume that he was going too deep to the palatal aspect. He was going to preserve the keratinized tissue, so that's why he placed the palatalized incision.
준비나?
But if you go to the palatal aspect, we know that there are many branches of the greater palatal arteries. And one of the minor branches were perforated, and we see the pumping bleeding of the arterial blood.
고개 저 있는 쪽으로 더 돌리시면 좋습니다.
Okay, so Dr. Root is trying to start with the osteotomy for the sinus flow elevation first, without placing implant placement.
Membrane is very close.
He has placed additional vertical incisions,
안 아프시다니까 아프실 때 대비해서
and now he's waiting for the second sinus floor elevation today.
이쪽은 아예 lateral approach를 한 다음에 합시다. 고개 이렇게 돌려보세요.
So we have to understand that there are so many surgeries combined together: implant placement, GBL, sinus lift, membrane perforation correction, and everything. So we have seen many surgeries combined together today. It was quite informative time for us. And he's using the simplified big diamond burr from Dr. Kit.
그리고 이제 멤브레인이 비춰볼 때는 이제
Now you see that he's
perpendicular하게
tilting 90 degree perpendicular to the window, because he once said that the lateral aspect of the diamond burr has more rotational speed and it cuts more aggressively. But if you tilt it, it becomes 90 degree perpendicular direction and it has less aggressive rotation.
Usually sinus elevation is very simple, but right side, unfortunately,
using
during the initial
mushroom
membrane was perforated.
Probe
Became
is going all around for the initial detachment. And luckily this time we do not have any more, no more perforations. So he's picking up the instrument from Dr. Kit, and I think that he's going for number 2. This is number 3 again. He's going for the floor. He's going for the floor first, and I see that he's touching the floor. And he's going for a little bit deeper and deeper. It's kind of a fan, the shape of the fan, and he's doing a fan technique, creating a small fan, middle fan, and large fan. So he's doing the fan technique to detach the membrane.
세 번째 기.
And I believe that he's going for number 4. Yes, this is number 4 elevator from the Dr. Kit.
움직이지 마세요. 상시 움직이지 말고.
So Dr. Root is giving the precaution to the patient: do not move, because there's a large chance that during the movement, because we are doing the flap membrane elevation, if the patient move, or if they sneeze, or if they do the heavy breathing in and out, there's a chance again for the perforation. So he's giving precautions and he's having a conversation with the patient. This is also another very good way to monitor the condition of the patient. Is it okay to continue, or are you having a pain? Are you having any discomfort? Keep asking the patient. Keep working with the patient.
고개를 이렇게 돌려보세요. 전체적으로.
It gives a very good information and a warm feeling to the patient, because what kind of procedure
Before
are
also
they?
I have tried to sinus augmentation with a particulate one. Nowadays is usually straight muscle. Very simply finished with a
Okay, like the right side, he's using the Osteon 3 collagen. 5 or 8% collagen is mixed with the synthetic bone osteon,
one more.
and 6.10 Osteon 3 collagen is slightly hydrated. If you do not hydrate it, you cannot squeeze it. It's very dense. But if you hydrate it, like you saw before, if you squeeze it, it crushes. So now he crushes it and then he spreads it.
One more.
Like I said in the beginning, I was quite curious how he managed to push and put the bone graft and spread equally inside the window, but now I got the idea. He crushes. He delivers the Osteon 3 collagen, but before the insertion into the window, he crushes
Usually
the
with
bone
Osteon
particles.
3 collagen we are not covered. Yeah.
And also he mentioned he's not going to use the collagen membrane because it's already collagenated. So it also reduces the
거의 다
turn time too.
끝났습니다. 이거든요.
Okay, it looks like a very clever surgical technique. So 3 Osteon 3 Osteon collagen
이런 거
was used without any membrane. And I think that he's ready for the implant incision, implant placement.
소킹.
He's doing additional bone graft for the sinus lift, or contour augmentation, I don't know. He's pushing it and putting the bone graft inside the sinus lift at the area,
바꿀까 말까.
and then
안 닫는다.
okay.
안 닫는 컨셉으로. 이쪽이 골이 보기 굉장히 좁으네요. 이쪽은 괜찮은데.
He's checking for the dimension, and very luckily the bleeding looks like slowed down. It was quite fast and a lot of amount of the bone was pumping out it,
약간
but now
alveolar
it's
crest
more
is
stabilized.
very thin, so we try to place the implant is little bit deeper to alveolar crest. 네. 스핀 하나.
Okay, he's connecting the parallel pin, so I think that he's ready for the second implant. Alright, he's taken out the second drills.
그런가? 그러죠 뭐.
You see that he's not doing the 800 or 1000 RPM, but instead he's using very slow RPM without any irrigation. In our conventional studies and belief, the bone was should be drilled with the high speed 800, 1000 or 1500. But nowadays we have a better implant drills with better cutting edges, and we have more evidences that this really does not induce serious heating from the bone, because we are using shorter implants these days, 8 millimeters, 10 millimeters. The bony heating that Dr. Erickson once mentioned was sometimes 13 millimeter, 15 millimeter.
준비하고.
But now you are placing shorter implants, so you don't see much bone heating. So the second osteotomy is done, and now he's picking up the tapping drill, the ridge spreader from ridge spreader kit.
리워드.
He's going inside and going for the reverse direction, and without any irrigation, he's going in and going out. Okay, Michael, the audience from the international, Michael asked us why Dr. Root used the small first incision on the left side. Why not he did not use the longer incision in the beginning? That was the same question that I had. We were ready for the implant placement and the sinus lift, but
1 millimeter,
why?
little bit deeper to alveolar crest.
So he's placing the second implant.
Very good initial stability.
A very
We have
nice
to
stability,
cut
primary
little bit
stability.
deeper.
It's going a little bit deeper.
And then, 예. 뭐가?
So Michael, I believe Dr. Root will give us the answer.
Yes, at first I will try the full breast surgery, ringalized full breast surgery on the left side. So that's the reason. Right side is a very typical conventional tech, but in the left side I will try the minimal invasive surgeries. But the position was not ideal, so I became the incision technique became to be changed. 힐링 업좀 주실까요? 적절하게 대답했나 모르겠어요.
Okay, so
멤브레인 두 번째 거 주고요.
that was the reason. He was wanting to minimize invasive surgeries, but there was a bleeding and there was a severe defect, so he decided and changed the
side
flap
bone
design.
alveolarity is a little bit wider than right side. So that's the differences between the right side and the different left side. I placed the implant 1 millimeter deeper. 좋아요. And so alveolar crest, I will do a little bit augmentations with the particulate bone or osteon collagen. So 잠깐만 일단 포지션 시키고 결정할까요?
Okay, he's done placing two implants. Okay, he's taking out the collagen membrane, not the collagen graft.
얘기하면 안 돼요 지금.
Why he's taking out the collagen membrane? Does he want to do the GBL?
참으셔야 됩니다 지금.
From his technique, I believe he will use just the osteon 3 collagen, not the conventional membrane and the
여기다
bone
본
graft.
그래팅하고
But maybe he will do the pin technique. Okay.
디렉션 양을 한번 볼까?
So he's pulling out a lot of tricks under his sleeve,
아프세요?
and we see many surgical variations today. So he saw that there is a deficiency on the buccal aspect from 2 implants,
It's very
additional anesthesia, and he wants to do the contour augmentation, but
몰랐어 이쪽도.
from the conventional way that Dr. Root does, he would have put just osteon 3 collagen,
그러면은 이
but
앞에
now
좀
he's doing the
나중 피라미드
different
좀
technique
아구멘테이션
from the right side.
심플하게 끝낼까요?
He's doing a little bit more flap elevation.
하나 더.
So we are waiting for his trick.
뒤쪽이 또 디펙트가
So what kind of surgical variation he will show us? I see there are 2 holes. Will it fit there? Okay, he's carefully. Wow, it goes inside. And the second one. So I think that he used the rubber dam punch in order to create in order to create the 2 holes. I don't know how he measured the 2 distances, but it looks like it quite fits the distances. Maybe he just placed 2 parallel incisions. But anyway, he used 2 holes, and using rubber dam punch, he's connecting 2 healing abutments. And this technique is quite similar technique to the conventional Gore-Tex membranes. This is what we did a lot of times. When we use the non-resorbable collagen, non-resorbable Gore-Tex membranes, we place the implants first, we place the holes, connect it to the healing abutments,
of the
and we
membrane,
did the
I will
GBLs.
try the fixation is the pin.
Okay, to better stabilize the membrane, he's doing the membrane pin. The membrane pin is quite easy to use, so he's using it a lot. And for me too, I use it a lot of the membrane pin. Easy to apply and easy to remove too. So if you do not have a chance to use the membrane pin, definitely you have to try. And then the GBL using the resorbable membrane will be very easy.
해드릴까요?
GBL pin was used, 3.2 millimeter, very short one.
엄마 이쪽에 이시전을 더 해봅시다.
I think that the flap is a little bit limited. Yes, he's doing additional incisions. It's the vertical incision, but it's kind of a cut back incision in order to reflect the flap advanced for the better closure. So he wanted to go for very minimally invasive surgeries, but now the defect is quite severe, so the whole flap is becoming the conventional 2 vertical incisions. And he's also removing the soft tissue from the bone, just like he did on the right side. And he's shaping the bone, because this bone is not particulated, it's collagenated, so it stays in shape, it's easier to mold. And now he's trying for the transmucosal GBL. This is not the primary closure. It exposes the healing abutments, and it's called transmucosal GBL. We believe that primary closure is the essential factor for the GBL, but Professor Hammerley and Professor Long, using the ITI, the Straumann type, and they have reported the nice results from the transmucosal GBLs. And the clinicians love this technique because they don't require any second stage surgeries. Maybe he wants to do the a little bit more. Okay, he's flipping the blade to the back, and using the back of the 15 blade, he's providing a scorching of the periosteum, not cutting, but just making scratches, and he gained additional flap advancement. It was also another very good technique, not aggressive. And he's ready to closure. Okay, he's using the pin again, not the suture. So we are seeing a lot of pins today. 5 or 6 pins on the right and 2 more pins on the left side.
것 같아요.
And he's measuring and thinking where to place the pin.
팔라탈 15번 브레이크로 해서 인터프록시말
I have no idea because I have not used this type of pin before. I thought only sutures could be used for the
too much
closure, but he's using the pin
it's
to have
not
the
easy.
closure.
So little bit
Is he going for the palatal
for the
incision?
closure.
No, he's going for Palachi incision. Palachi incision is the incision is a kind of a pedicle incision to cut the keratinized tissue and rotate it and to place it between the implant fixtures. So this was quite famous technique for especially for the Brennemark implants.
멤브레인하고 핀하고
But he has performed 2 Palachi techniques, and he is rotating the pedicles around the implant, and now he's using the pin, not the suture.
됐어요? 잘했어요.
Wow, that was easy. That was very easy. Just molleting 3 or 4 times, and the flap is nicely secured.
여기도
I don't know what is the result of the membrane pin because I maybe fear that the membrane pins will fall out during the healing period, but Dr. Root said it's not easy to remove automatically because it has some certain length. So it looks like it's quite a safe way to stabilize the pin, stabilize the flap. So we will have to see the results. Hopefully the healing results from these specific surgical cases, Dentium will provide the results from the website. I'm not sure, but I will have the Dentium to provide the healing results because I'm very curious about the healings. On the right side, it looks like the primary closure at this moment, but I don't know, there will be some dehiscences or exposure. So on the right side, we have to observe for any dehiscences. And on the left side, I want to see what kind of healing the patient will have because there was a lot of bleeding from the palatal side, and Dr. Root has shifted keratinized tissue to buccally and how the keratinized tissue will be regenerated.
괜찮으세요, 교수님?
So we will see in a couple of weeks later from the website of the clinical Dentium.com, I hope. So he's using the silk size 4-0, and in this case it's not interrupted suture, but he's going for horizontal internal matrix suture, I believe. Going buccal and lingual and going back from lingual to buccal again, and then he's creating a tie. And this one kind of pulls up the whole buccal and lingual flap to the crostally and provides the eversion of the flaps.
야, 이제 인터프록. 이럴까요?
So audiences from the all around the globe, please understand that we are having a very late hour surgery, so
조금 더 아구멘테이션.
everybody is having a very difficult time, I believe. So we are looking for a good way to properly finish this surgery without any problem in a beautiful primary closure. So Dr. Root is especially thinking hard to have a beautiful soft tissue management. Because these days the biomaterials and implant fixtures has developed substantially and it's quite difficult to fail. The implant success rate has go high. But only one aspect that many clinicians have not mastered is the soft tissue management. Soft tissue management requires a lot of training, a lot of observation, and a lot of clinical experiences, which requires a lot of failure too. So soft tissue does not play alone with you. So it's a very tricky tissue to play with. So Dr. Root is trying to thinking of a way how to expose the healing abutment. Maybe he will just go for some kind of a half submerged healing abutment, just like the Straumann or ITI implants used to do. They intentionally half submerged the implants with the healing abutments, and it allows us much more soft tissue regeneration, slightly on top of the implant fixture. And then we have much more soft tissue to play with to deliver for the aesthetic crowns. So Dr. Root is almost done with the surgeries, and I was told that he will provide the zirconium and the pre-fabricated
I will try to place the
implants.
palatal implant further.
So because we are almost finished, we will have similar cases overview. Dr. Root has shown us a very similar cases. This is the free gingival graft using GBL plate and GBL pin. On the lower left side, Dr. Root has placed 2 implants previously. And then we see that there is a lack of the keratinized tissue, vestibule. So Dr. Root is connecting the healing abutments, and in order to have regeneration of the keratinized tissue, he's picking up the collagen membrane. And he's doing the GBL plate and GBL pin.
During the second stage surgery, we will do a little bit label augmentations.
And this is after 1 week, 2 weeks, and 1 month.
If there are
And
deficiencies,
this is the final prosthesis.
augmentation during the second stage surgery. But
So this is the
we need some
similar cases, and look at Dr.
retention
Root is
of
finishing
the
his
temporary
surgery.
dentures. So in this side is very critical with the bone grafting. So at first I will go place the 1 palatal implant for the retention of the temporal dentures, but sometimes we can place the 2 implants for the stabilization or retention. 원영 교수님 palatal implant 어떠세요? 괜찮으세요?
So he's talking about the temporary denture. For the
Yeah.
stabilization of the temporary denture,
그래서
he's placing
2
the
millimeters
palatal
inside
implants.
the
So he's
with
using
palatal
a
area.
specialized palatal implant, and then from this palatal implant, the temporary denture will receive the stabilization. So he is showing us the palatal implant for the retention of the temporary denture. And also after surgery, Dr. Root will go for intraoral scanning and also scan beam CT and X-rays taking, and he will show us the results after surgery 5 minutes later.
4.0에 7.0 심을까요?
So he's thinking of the diameter and the length of the implants.
네, 좀 죄송해요, 선생님.
And he has
조금만 더
placed
하면
the
됩니다.
incision, a very small incision, and he's using the conventional drills for the palatal implantation. It looks like he's just doing the drilling, but in fact he has many information from the Conbeam CT and 3D reconstruction. So he's placing the palatal implants in the pre-plant positions. So he's creating 2 short implants. Diameter is 4, and the implant length is 7 millimeters. As far as I understand, the Dentium short implant of the 7 millimeter will have 2 types. The rough surface goes all the way up to the 7 millimeter, or sometimes they go 5.5 millimeter, and 1.5 millimeter on top is the smooth surface. So I don't know what kind of implant fixture he will use. Okay, that's the second one that I mentioned. 5.5 millimeter is the rough surface, and 1.5 millimeter is the smooth surface. And the Dentium fixture usually provides a very nice primary stability. So Dr. Root did not have any problem to place the implants. And he's going for the second implant. And please be noted that this implant should be removed after the temporary denture. So he's placing temporary palatal implants on the palatal aspect. Now he's using again 4.0 and 7 millimeter, but 5.5 is the rough surface and 1.5 is the smooth surface. So these two short implants will provide the stabilization for the temporary denture. And on the right side, it was completely primary closed. And on the left side, the healing abutments are partially and intentionally exposed.
이쪽은 아까 돌리면서 헛도는가? 안 들어간 것 같죠? 예, 4.5 하나 줄까요?
Okay, maybe he's looking for the healing abutments. He's
One more
connecting
wider
healing abutments
side in
or
the
cover screw, I'm not sure.
Left side.
Okay, oh, he's removing the implants.
아이고.
Okay, he says there's not enough primary stability. It looked like it has quite stability, but it was not.
Complication 해봐야 돼.
So he's going for, instead of 4.0, but he's going for 4.5 and 7 millimeter implantation. I hope that this one gets better primary stability.
될 것 같아요, 이 정도로. 아니면 커버 스크루를 했다 할까? 네, 커버 스크루에 first.
Okay, he's talking about the cover screw, so it looks like he's going to close it with the cover screw.
템포러리 렌즈 빨리 할 거니까 이게 볼이 제일 두께가 길이가 짧은 건가요? 네.
So anyway, this one is the only
그냥 이걸로
temporary,
하겠습니다.
only temporary implant for the temporary denture. So we do not worry about the osseointegration or implant level or nothing else. Only for the primary stability is the important. So these two bowls are for the temporary dentures. So that's a very nice way to provide a very nice anchorage for temporary denture.
원형도
So he's
선생님이
using the same instrument to close these bowls to the implant fixture with the right final torque. Alright, so after these two surgeries and two temporary implant placement, it looks like the surgery is all done.
뭐 체크바이트까지 아예 떠서 템포러리 덴처를
Okay, he's talking about he's providing the temporary denture and
이제
inside
끝났습니다. 잘
he
됐습니다,
will do the
선생님.
occlusion checking.
인터그럴 스캐닝하는 것도 보여드려도 좋을 것 같죠?
And also he wants to show the intraoral scanning for us. So the surgery is done.
아이오백으로 할까?
He's doing a lot of irrigation to remove
다
the
좋습니다.
soft
잘 나오는 게
bleeding.
어디예요, 연조직 때?
And he's
3쉐이 터져요? 그럼 그렇게 합시다.
and he's ready for the
둘 다
intraoral
보여드리면
scanning.
좋거든. 예, 이제 됐습니다, 일단. 또 스캐닝하고 체크바이트는 원영도 원장님이 또 퍼티로 해서 딱 띄워주시면. 네. 아예 아닙니다, 교수님. 아휴, 죄송합니다, 그냥. 아휴, 그냥 좀 어렵게.
Okay, sorry for too much noises. I think that they are closing up the surgical side, so that's why we have a little bit noises. Okay, thank you for watching this video. Thank you for watching this video, and we will see a little bit of the presentations. Many people asked us about how we deliver the medication and how we provide the precautions to the patients. Today we have seen 6 or 5 implant placements, a contour augmentation, aggressive periosteal releasing incision, sinus grafts, perforation, and bleeding. So everything was in one box. So it's a lot of things going on. What kind of precaution we should give to the patients? We have to allow the patient to understand the healing procedure. There will be a lot of pain, swelling, and additional bleeding. So we provide the additional sterilized gauze to provide the manual pressures, and also we provide the medication. Like you see from here, antibiotics and anti-inflammatory drugs and digestants all in combination will be given for 7 days. and the patient in fact has received pre-medication a day before, and the patient cannot brush. Of course, he can brush on the mandibular side, but he cannot brush the surgical side, so we will provide the chlorhexidine irrigation, and he will do a lot of gargling to remove the plaques and reduce the inflammation and the infections. So that's what we expect. The intraoral scanning is almost ready, so if the scanning is ready, we will move on to the surgical site, surgical room. Please tell us if the surgical scanning is ready, so we will be ready. Today we have seen many advanced surgical techniques. If you are a beginner or if you are not really ready for these advanced surgical techniques, you have to practice one by one. So we will jump to the surgical room and we will see the scanning. So please give me the video on the monitor. Okay, this is a video of the mandibular side. So you go for the occlusal view first and then tilt the scanner to the lingual side, and it's picking up the images of the interdental areas too and the lingual aspect. And then you rotate the scanner to buccally, and you go also and pick up the images of the interdental areas. It was quite fast and very straightforward scanning. And going back to the buccal aspect on the lower left again. Okay, I think that the scan is almost done. Occlusal view and the lingual. So he's going for the occlusal view again, picking up the images. Okay, the scan is almost done. So scanner is ready. It says the scanner is ready on the mandible and it's going for the upper area. So, okay, this is the surgical site. This is the surgical site. We see the membrane. When we have a bleeding, so it usually reflects the light, and it's very difficult to pick up the area. But today we are seeing a very good, very nice scanning. Very good. Going for the palatal implants. Okay, he's going for the palatal aspect. Now he's going for the buccal aspect. Now he's overlaying of the previous images and overlapping and making more clear. So using this oral scanner, I believe that it will provide a temporary denture, and Dr. Root will check for the occlusion using this information. Okay, once we are done with the scanning, okay, I think that we are done with the scanning, and we will see some short videos, and we will come back for the final session for the Q&A in 5 minutes. So we will see some videos, and thank you for watching this surgical video, and do not go away. We will come back in 5 minutes. Thank you very much for watching this video. So we are back from the little short break, and I hope you enjoyed the videos. Okay, this was the very exciting experiences for all of us, especially for me. This is my first time to moderate and broadcast the live surgery, and I hope that you also understood my situation and quite enjoyed the first live surgery. Today's exciting surgical cases has provided many answers to the question that many clinicians have: how to perform the contour augmentation, how to place the implants in an extremely deficient bone, and how to manage the perforated Schneider membrane and finish and close up. So Dr. Root has showed us many techniques, and there were hundreds of questions from all over the world, but due to we have limited time, so we have chosen two questions, and we want to provide the answer, hopefully. Dr. D, when doing a ridge splitting, what should we do if the buccal bone got separated or broken? It should not happen. So I should, this is joking, but it should not happen. You have to evaluate the concavity of the buccal bone and the sagittal view. You have to clearly have the image where to place the implants and to what depth you're going to place the implants. Otherwise, you will be ending up with the fracture of the buccal bone. But eventually, if the bone is taken out, maybe you will believe that maybe this is a type of the block bone, or sometimes you can screw it to the lingual bone, or you may take it out and you crush it and use it a particulated autogenous bone. It's your option. But for first time, for the beginning, you should not break it or lose the buccal bone. So that's the first mission that you should do. We will go to the second question. The second question was quite more interesting. When will you remove the membrane pin from the soft tissue? We do not have any answer to that because this is a quite new technique, but many clinicians, especially the periodontists, had dreams like this. When you do the free gingiva graft, you can imagine we place hundreds of small sutures to the periosteum and to the adjacent soft tissues. It takes time, it's very difficult, especially if the posterior area, it's difficult to approach. But if we have a pin like this, or if we have a plate like this, you just take out the soft tissue and you close it and you just tap it and it's done. It will be fantastic. But the reason that we do not have this technique with us is, many cases these pins are non-resorbable and they are made of the metals, and once it falls out from the bone, there's a chance that the patient will swallow the pins or the plates. So due to the fear of the swallowing or falling out of these materials, we did not use the pin. Rather, we use the cyanoacrylate, the adhesive, instead of doing the suture, or we just do the sutures. Or sometimes we use the periodontal pack. But now we have these technologies. We do not have enough evidences yet, but we have nice results from Dr. Root, and hopefully we will have a lot of fun with this technique. So we are expecting this X-ray from the patients, and as you can see from the monitor, this is the final situation. Beautiful placement of 3 implants, and you see the 2 implants are inside to the palatal bone. It's not the incisal implants, but it's the palatal temporary denture anchorage implants. So these 2 implants will be taken out, and you see that the nice bone augmentation. This is amazing because if we augment it with the particulated bones, it will take 5 or 10 minutes. But you take out the collagenated bone, you just push, 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 and after 3, bone graft, and it's done. And do you see the nice outline of the bone graft, especially on the left side? But due to the perforation to the right side, the outline is not clear, but it's not bad at all. So 3 implants on the right side with a simultaneous bone graft, sinus bone graft, and the lateral contour augmentation was nicely done with many membrane pins. And the left side, 2 implants are nicely placed, and the nice sinus bone augmentation was done. So We will come back with the healing results, and please check the clinical Dentium.com website. In a couple of weeks later, Dentium will provide the healing results of this specific patient. So thank you for bearing with us, our first live surgery, but we will prepare better, and we hopefully will come back in November with more exciting and more advanced and informative live surgeries. Thank you for watching us, and thank you for staying us. We will see you in a couple of months later. Thank you very much.